Hi, everybody. This is episode 64 of our podcast, Artificial Intelligence and Cybersurgery. My name is Andrew Gums. I'm the editor-in-chief of Artificial Intelligence Surgery. This is our official podcast. The journal is the first journal and maybe the only journal dedicated exclusively to artificial intelligence and surgery. I'm here with my co-host, Professor Dr. Vincent Grasso, who will introduce our next guest. Okay.
Thanks, Andrew. It's I think you said 64, right? Season 3, episode 64. We've done a lot of interviews with very interesting people, and we have another interesting person, surgeon up at BAT, Professor Dr. Gregor Stavrou, who is a hepatobiliary surgeon in Germany, and we're very excited to have you on our podcast. If I may call you Gregor, and please introduce yourself and your background to our audience, and we're looking forward to speaking with you. Thank you for joining.
So where are you located now?
I am in Saarbrücken, which is basically on the southwest border of Germany, quite close to Luxembourg and France, of course. So when I look out of the window, I have France just there, so we can go shop for baguettes and croissants every week and these things. So,
how far are you from Strasbourg? Sorry, how far are you from Strasbourg?
Strasbourg is about 1.5 hours drive.
Okay, so you're north then.
Yeah. So there's these two regions in France, which is Alsace, and this is where Strasbourg is the capital.
Yeah.
So this used to be like a German region, more. It was always, sometimes it belonged to Germany, then it belonged to France, and vice versa. And it's here. This is Département Moselle, so Lothringen. So actually, the people that talk, like the French people over the border that are the original inhabitants, they have a dialect which is a German dialect, so they all know German in a way.
Yeah, but in on the German side, it's not like they speak French. No,
not as good, probably. No.
Yeah. And are you originally from there?
No, I was born in Munich, and then I moved to Hamburg because of my father when I was 18, and then I've been all over the place studying and working. And so I started in Essen University. My first boss was Chris Brölsch, the father of living-related transplant surgery. So this was very intense and interesting first years. And I had two attendings that have sort of accompanied me all my life. One is Hauke Lang, who's the chair in Mainz, and the other one is Karl Oldhafer, who became my teacher later from Hamburg. And so then I made a little excursion to anesthesia for a year, because I thought it was quite clever to know what the guys on the other side of, the other side of the room are doing. And I did this for a year, and then I returned back to surgery, and Karl taught me everything. So
you would have been a trauma surgeon in America, because in America the trauma surgeons do critical care. They have specialization. They do 1 year of training in the ICU and a year of and plus minus a year of trauma surgery. But it sounds like that would have been a nice combination for you.
Yeah. Well, I just wanted to see what the whole fuss about anesthesia was about, in a way. So
no, I love intensive care. I thought about doing that in America. I think it's great that you did that. It's very nice. Another thing, Vincent, you may not know, but the intensive care unit is really like a separate department. The surgeons have very little control over there. Wow. And it's beautiful on one hand, because they take care of the patient really so well for you. But on the other hand, the surgeons I have found in Europe don't have the same amount of expertise, or maybe I should say interest in dealing with ventilators, dealing with sepsis, dealing with pressors and everything. And it's something I miss. So I actually try to spend as much time as I can in the intensive care unit regardless, and look at these things, because I miss it.
I think it's super important if you do big surgery, you need to know something about intensive care medicine. So how nowadays in Germany, usually, at least over here, it's organized. It's like an anesthetic department. The anesthetic department does anesthesia and intensive care, and as surgeons, we are just there as visitors. And our residents have to do a rotation of 6 months during their training.
Oh, that's good.
Every general surgery training
In Germany,
yeah,
everyone?
it's mandatory.
Oh, that's great. That's great. Yeah, I don't think it's the case in France. Yeah, it's not like that.
No, actually. So in Germany, you have to do that. And I think it's good to get to know intensive care. But what I did was I spent some time on ICU as well, and even before as a surgeon, but I really did anesthetics in the OR.
Yeah, no, I understand. No, of course. No,
So,
that's what I
I thought
figured.
that was also interesting. I mean, it was super interesting. I was in Hamburg at that time, and I also did anesthesia for transplant cases, which I only knew from the other side. So,
Yeah.
I mean, anhepatic phase, I found quite boring as an anesthetist, but when they had reperfusion, that's
Oh.
another story for the anesthetist.
Oh, absolutely. Absolutely. A
Very
lot of bicarbonate. Yeah.
So, well, yeah, and then I had this, I mean, from the beginning in starting in Essen, HPB was sort of written all over. And of course, in Germany, we do like everything in a way. So my training is still like a complete range from thyroid down to the rectum. But my focus was always HPB, and that's also what my main interest is.
When I was a medical student, I spent 1 month at Inselspital in Bern with Helmut Fries and of course Marcus Buchler. So that was my exposure to the German system.
German world. Yeah.
It was very funny because I show up with a white coat and a tie, right? And everyone else there had that coat that buttons in the back.
Okay.
You know, everyone except Marcus Buchler, who had a tie. And from that moment, many of the Swiss surgeons were unhappy at me because they thought it was like an arrogant thing to wear the tie. But it's a very interesting culture shock.
Yeah.
Not to compare Switzerland and Germany, but you know.
The tie thing in Germany is liberal in a way, or it's sometimes at universities they do that. I never got around wearing a tie, and I always thought it was I remember when I was in the US, I had to wear a tie, and I didn't really think it was a very clever idea to have a tie in the hospital. Yeah. But
I love the German
just have a t-shirt.
Yeah, but I love the German white coats. They don't even have the lapel. They just have.
Yeah.
So cool. Like it looks almost Asian, you know, like the Beatles, like the Nehru jacket.
The Zen coat.
Class, baby. So I'm sorry to talk so much about Germany. We digress a little bit. So now, are you mainly doing transplant surgery?
No, transplant we don't do here. So this is a big general hospital and a teaching hospital, and we do everything. Basically, I'm the chief of surgery, so we have general, visceral, thoracic surgery, and surgical oncology, and I set up a liver and pancreatic service here because there was nothing much going on before I came here, and now I'm here for 7 years, so we managed to do around 60 pancreatic resections a year, around 70 liver resections. So that's some numbers you can also train somebody on.
Yeah.
And we also have certificate for colorectal cancer. So we do. I have a super team. I have some people with me. It's so much fun. I mean, we all started here together and sort of challenged us, and they helped me, and some of them were very educated in laparoscopic surgery. So we really, when I arrived, I said, look guys, I want to do this minimally invasive. No matter what we do, I want to do it minimally invasively. And we started this program for colorectal surgery, and that was a big fight in the beginning, but then really successful. And we also I have this attending surgeon. She's into bariatric surgery, and I just gave her sort of the support to really set up like a center of her own in the department. So by now it's a big service. It's 200 metabolic operations a year.
Nice.
And really cool. So this brought us to the point where I had always the problem, for example, with gastrectomies. There's no problem in cutting it out laparoscopically. I had the problem, how do you reconstruct? And then I said to her, why don't we do this together? And I do the resection and you do whatever you do 100 times of the year. Don't think about it.
Yeah. That's smart. Yeah.
So we started to do this reconstruction like in bariatric surgery, and this works super.
Do you know Roland Kroner at Magdeburg?
I do know him, but he's one of the very few that I don't really know very well. I've met him a couple of times, but we never had a sort of deeper contact.
We have to put you into contact. I probably never told you, but I'm actually a professor of surgery at Magdeburg, so I go there quite often. So how far are you from Magdeburg?
Well, that's quite a while. I mean, that's like 600 kilometers or so. It's quite straight across.
Right.
So do you do visualization with Bernhard Preim, or because I had ties with Magdeburg before he came there, because we've done a lot of research I worked for 20 years with MEVIS and 3D reconstruction, and we had a project of navigation and liver surgery. And Bernhard Preim, they have a visualization institute in Magdeburg.
Yeah, they have an amazing radiology there, which is definitely very interesting. One of the reasons I'm there. But no, I work exclusively with Roland.
This institute is not a medical. It's a technology institute.
Yeah,
from the University of Magdeburg.
Yeah, no. I mean, I know they're very good with MRI, and they have a research center, which the name of the location is escaping me. But no, I'm just with Roland, but I'll look into that.
He's the one that I think he was more or less the first one to try robotic surgery for liver surgery also.
In Germany,
at the time we started laparoscopic surgery or liver surgery. So that was for me for many, many years to try to get that up to the possible borders. And I've got a robot now. So since last week, I'm on the robot. So I'm really happy. So we will start liver surgery.
Great.
I think by March I will start the program. So I have to feel comfortable, and then
nice and slow. You might want to do some of those gastric reconstructions with the robot before you know, if you need to put a suture with the robot on the portal vein, well, you do it laparoscopically.
So I think it's
okay. You'll be fine.
I'm not afraid. I mean, I've been trained by Björn Edwin in Oslo. So I went there for like a week or so, and I had a long contact with him beforehand. And
that's great.
This was fantastic. I mean, I was lucky to have the experience of, I don't know how many liver, I mean, we did over 200 liver resections per year in Hamburg. So from small resections to antesitum. So I've seen so much. So once somebody shows you some tricks of how to approach things differently because you're in laparoscopic surgery, then you can sort of transfer it. And Björn was a perfect teacher. We really, I mean, I went there with my attending and the theater nurse, and we spent this week with him in Osmond, and we had patients scheduled for the next week. So we did like 4 laparoscopic operations, and from then on we just started and gradually even start with big tumors. And by now we are like 55% of cases we do laparoscopically.
Nice.
But obviously reconstructions, and that's, I'm hoping, for the robot for complex cases, and like segment 8 or 7 is just such a hassle. If you do it laparoscopically, it's a pain in the ass, really.
Yeah, definitely. No,
people keep telling me with a robot, Mathieu Dont always says, it's a walk in the park if you do it with a robot. And we'll see. I
We'll
don't
see.
know.
Yeah, no. It's a the reason I'm asking is we have developed a robot where the surgeon stays in contact with the patient that doesn't sit down. That's why I was trying to gauge, because I was actually thinking if you have a very long laparoscopic history with liver surgery, I was thinking you might be one of the centers that we could get you this robot once it's up and running. But we'll talk about that offline.
Is that like there was this Swiss company that had this kind of robot, but they never Dexter?
Well, there's no console. It's just at the bedside entirely. So you're sterile, you're scrubbed, and the arms are right there you're with the patient at all times.
Okay.
Yeah, I'll one of these days
Well, actually, my dream is that I get like with 5G, I get like a little mini console that I can take to Cyprus to my holiday home and just log in and do some. That's actually the thing that would be great. So,
well, you're not the only one. Dennis Fowler with remind me what it's called, Vince. Is it Sovato? I think it's called Sovato.
Yeah, I think Sovato, yeah.
So that's exactly what they're developing, is basically the connectivity so that surgeons, probably mainly in America and then in Europe, are able to do just what you're saying, that they'll be able to operate patients around the world. That's a whole discussion. I think that's a little bit crazy, especially if you have a complication and you're 1,000 miles away. But the reason they're developing it, or the reason it's getting big American, I think, military dollars, is imagine if someone on the moon has a problem,
I don't even go to the moon. I mean, I'm a reserve officer of the German army, and we had this discussion before. Do you send a doctor, like a surgeon, a trained surgeon, to Afghanistan? And of course they have to do that, but if you think about it, it's stupid. I mean, if the guy gets injured, it's not that you send somebody new. I mean, you need 20 years to train someone to do this kind of operation. So it's a fair call to say you need somebody with I would say if I am in Cyprus and my team operates someone, if I can't solve it from Cyprus with a robot, they could at least do it openly, whatever. But I see that this discussion will be, I don't ever think from an ethical point of view that would it be accepted that the surgeon is away.
Well,
I don't know.
It depends who's calling the shots, right? I mean, you've seen the political shifts in certain countries. So, I like to use this example. I was flying back from Houston a few years ago, and we landed in New York, and the landing was very rough. It was just like it was just a little rough. We were shaking afterwards, and the pilot came on and said, "Oh, sorry, everybody, but we were using Autoland." So I was like,
"No way."
So I Googled it when, and I was like, "What the hell is this?" And they used artificial intelligence for landing. They didn't get my consent. They didn't tell any of us. And essentially, they risked the lives of 300 patients at the same time. So I wish what you said is correct, that it won't ethically be allowed. But unfortunately, the dollar money, greases the wheels of everything. So my solution, for instance, let's just stop making war. But of course, no one's going to list me on that, but I digress.
Unfortunately not, I guess.
Because
there's too much dollars you can make. So
exactly. Oh, exactly. But Gregor, as you know, we're on the innovation committee together, and I was very interested in your work in augmented reality. I was wondering if you could give Vincent a little bit of an update of what you're doing and what you're interested in.
So this is another coincidence in life, as it goes sometimes. This is a lucky shot, I would call it. I've shown Andrew the paper and everything. So basically what happened was that I have a very, very, very bright resident who used to be a research fellow in Heidelberg, and then he came to train with me, and he's always been helping me with research in these things. And the starting point was a patient where we had to do an Applebee's operation. And I was a little, nervous about that because it's not the operation you do every day. or you see it like 3 times in your life as an HPB surgeon. So I was a little, and I did a 3D reconstruction with the Mavis software, so to have a better clue about the vascular structure. And he said, well, I told you my wife is working with the German Artificial Intelligence Institute, which is the DFKI, which is one of the biggest central AI institutes in Europe. And she's a research assistant, and maybe we can talk to her, so because she has these HoloLenses, and maybe we can transfer it to the CISO. So we talked to her, and she said she was absolutely happy. The good thing is, at home at night, he would explain her everything about surgery and all these things. So that's a totally different angle towards things. So it's not like you have a meeting and people try to understand. So she, at home, he made a picture and he explained to her. So
she saw the reality of him being called in the middle of the night to come back for bleeding and how much
exactly
in their life. So this is great.
So Hamunas is a super bright computer scientist, and she came up with, so we had a chat. So she said, what do you want? And I said, okay, what I would like is to have the HoloLens and to see the anatomy on the field. And I said, the problem is, and I've been through that through many projects, is registration of the plan to the operative field. And she said, I have an idea. I said, okay, you go for it. And she came up with this QR code thing. Basically, I would have never had that idea, but it seems like that with all the new technology around, that the QR code mapping with and Andrew, you know much more about that than I do, but with the HoloLens and the cameras, and I mean, the processor in the HoloLens is more powerful than all the processors we had for the navigation projects 15 years ago in the big computers. So what she does is actually with the QR code that we can define in its location, she can register continuously the model into the operative field. And that's a great help. It was a step forward. In 2-3 weeks, we made more progress than with so many projects I've seen more or less fail over the years. So we had that sorted, and then I said to her, well, it would be nice if I also could have a look at the CT scan and some patient history, and she just programmed that all into one app on the HoloLens. And now we made a study out of it, and we actually I was surprised. We found that we were very effective with this, and I said to her, look, I mean, there's 2 ways we could follow this up. So one is to try and get the support of like a society like the EHPBA to make a multi-center trial out of it. And I think it's a fair shot. Maybe we managed to do that. I personally think the biggest benefit of that is will be education of residents. That was, Andrew, you said it. How was it called? Mal nach Zahlen. Drawing. You came up with a correct. For the kids, drawing up. Drawing.
I can't remember.
When you have a kid and you have numbers, and those numbers will be a Mickey Mouse in the end. So they draw. They draw.
Like drawing by numbers.
Drawing by numbers. So
okay.
That's my idea, that you can use this thing in education as a drawing. Usually, well, at least in Germany, to prepare a liver hilum, you would be probably in year 6, maybe even later.
Yeah.
So I think with the HoloLens and the workup, you can do it in year 2.
Wow.
And by year 6, you'll be perfect in doing it without it.
So explain to us the workflow. Are you wearing the HoloLens while you're operating?
Yes. You have the HoloLens, and the HoloLens is just overlaying the operative field with the anatomy. And it works. It works very precise. So
does it fit in the Da Vinci?
That is, of course, we're talking open surgery now. So
yeah. So you don't even use it laparoscopically.
Yeah, but that is not so easy because of the reference points. I mean, in navigation technique in laparoscopy is very difficult just to implement, and it's always the same problems. It's two problems: registration of the plan and organ deformation. So this is the problem with that. And for open surgery, at least for pancreatic surgery, I would say is mainly open surgery nowadays. And for this, we have a solution to train people. I don't believe that we will, I mean, I don't know, but I cannot see that we will train surgeons only on the robot for pancreatic surgery.
I hope not. I hope not. You know,
I don't think, I'm not even sure. I mean, I am thrilled. And I said, my plan is that I do the first robotic Whipple like in 18 months or 2 years. I want to do that. But
yes,
if you look at the data, it's quite frustrating, right? I mean, it's not that it shows that it's so much benefit.
correct. It's, I mean, you know, we all know it's a very difficult operation, no matter how you do it.
Yeah.
You know, that's the bottom line.
And if I look at the patients that are operated on videos, I don't see patients like that. Like we only have like these tumors, and I have 80% venous reconstruction. That is scary. I saw that there was a very good video by Riccardo Memio the other day on LinkedIn. I don't know, you know the guy? It's a crazy,
of course.
crazy Italian guy. So the video was called Vascular Controlled in Pancreatic Surgery, Not for Tourists.
Yeah. I'm never going to watch that film. He's going to give me flashbacks and nightmares. No thanks.
So he goes on the below the portal vein, trying to get off the pancreatic head, and he has a massive bleed. So this is either the SMA or like a big branch of the SMA.
Yeah.
I think he did it quite. I mean, he was cool. He solved the robotic. I mean, the patient would have been dead if you convert. That's for sure.
Yeah.
I'm still not sure if he just didn't close the SMA completely with his suture, but this is really a tough one.
Yeah, no, it's my whole problem with augmented reality in general at this phase, and maybe Vincent, maybe you can give us some clarity. How the hell is money going to be made? And what I mean by that is if nobody can make any money, who's going to invest in it? How is it going to develop? How's it, I see the benefit. Don't get me wrong, I see the benefit, but I don't see yet how it gets paid for. Do you have any insights, Vincent, you can think of? Because training, as you know, training is great, but I'm not sure that transfers into money.
Until it becomes almost mandatory as a must-have rather than a nice-to-have. It's a luxury. It's a research tool. It's, certainly for training, it's fantastic. But, everybody's trying to move towards virtual reality, right? So everybody wants to go fast. And I'm so excited to hear what Gregor did with his associate and his wife. It's really interesting. You and I have talked about this a long time. If you have a really smart software developer, data scientist, really smart, and you have access to the relevant data, and you have the domain experts like Gregor and his associate, you can come up with what they did, the 4 people.
Yeah.
And so, you don't need 55 software developers working in a lab trying to build stuff. You need really smart people that identify a problem, and you have access to the data. If you don't have access to the data, then it's all an exercise in futility. But Gregor, you seem to have a very nice ecosystem there to be, innovative.
Just pure luck, I would say. I mean,
Well,
really a lucky
nothing
shot
wrong with that.
And the right people in the right spots. So that's very helpful. And by now we have the full support of her professors.
Wow.
And there's a whole power of the DFKI. And I mean, I didn't even know what kind of institute that was in the end. So, they have 2 sites, one in Kaiserslautern, one actually in Saarbrücken, which is the main branch. And I saw the chief of this institute the other day on a conference, and he was giving out the plan of future AI development, and he had the plan is that DFKI is like the CERN for AI. So he had this world map with New York,
Wow.
Tokyo, Saarbrücken as the center. I was like, okay, I like that idea, but
Yeah, yeah.
um,
What does Saarbrücken mean in German? Sour bread?
it's the river Saar,
Ah,
and Brücken is bridges. So it's
Bridges.
basically
Ah,
quite
okay.
often actually you find that in Germany quite often that cities are named by the bridge that was built over this river.
oh, nice.
And because
Nice.
it was the logical point to start a city next to the bridge to do some trade. and
Oh,
stuff.
definitely. Trade. It's all about trade. That's what we've been talking
Yeah.
about.
Money.
So we only have 4 minutes left. So Vincent, why don't we close this out so we have a few minutes to talk to
Sure.
Gregor before our Zoom expires?
Well, it's been a great pleasure to have our new friend, Gregor Stavrou, professor, doctor, hepatobiliary surgeon in Saarbrücken, Germany, and he gave us some great insights into what he's working on and the excellence at his facility. So we'll close up episode 64, season 3 of our AI and Cybersurgery podcast within our journal, Artificial Intelligence Surgery, the only journal we think dedicated to all things AI. And we'll talk soon, Gregor. Thanks for being on.
Happy to. Thank you so much for having me.
Thank you.
Thank you.